So we are moving to the scientific session 3, workshop on diabetic food. I would like to call upon the chairpersons, Dr. Madhu Periyasamy and Dr. Ilay Kumar, to chair the session and take over the session. Dr. Madhu Periyasamy, I think we are finishing all the sessions at time, and I would request the same thing for the chairpersons to keep everything on time. Thank you, sirs. Take on. Yeah.
Good morning, everyone. Yeah. So from to more earthly levels from our previous topic. So I invite Dr. Madhu Periyasamy. He'll be talking on the architecture of the food, the very foundation of diabetic food care.
Thank you, Dr. Ilay Kumar, and good morning to the audience. This is going to be I think two of us surgeons sitting here amongst an audience of physicians. So we'll try to make sense of what the surgical perspectives on the diabetic foot are. So first and foremost, I would like to go upon the anatomy and the biomechanics of exactly how the foot functions, so that we later understand why we do the operations that we do. So going back a lot of years for many of us to the anatomy of the foot, the most important layer of the foot is the sole of the foot, the skin and the soft tissue. It consists of the plantar skin on the outside with a subcutaneous fat, which is attached by multiple collagen strands to the underlying musculoskeletal system. But if you see, these are all compartmentalized, and the subcutaneous fat actually mirrors the underlying skin and soft tissue, musculoskeletal area, so that there is a maximization of the contact area. So this is what we must try to do when we design footwear also. So this is a God-given principle that we must try to duplicate when we design footwear. Below that is the plantar fascia. It is an extension of the Achilles tendon. It acts like, where the calcaneum acts like a sesamoid. So the superficial most fibers of the Achilles tendon will travel across the calcaneum and insert onto the forefoot, to be very specific, at the base of the PPX of all the toes. In fact, this lets you know why the Achilles tendon tends to act on the forefoot. We'll come to that later. Beneath that are the three muscles: the abductor flexor digitorum brevis, the abductor hallucis, and the abductor digiti minimi. Second layer consists of the extrinsic tendons coming into the foot through the porta pedis, and you'll notice that all of these come through the medial side, and automatically the toes will have a tendency to curl medially, if not for the quadriceps plantae. This muscle helps to pull the tendons to the central side. So when there is a intrinsic paralysis of this muscle, again there will be a crowding of toes, and that is what causes a lot of intertrigo. Beneath that layer is again a layer of intrinsic muscles, and then the deepest layer, where you notice that the peroneus tendon, the peroneus longus, actually curves around the lateral side of the foot and inserts onto the base of the first metatarsal. So this is very important for first metatarsal head ulcers. We'll see that later in the talk. On the dorsum are the extensors. The tibialis anterior, extensor hallucis longus, extensor digitorum longus, and the peroneus tertius. And on the lateral side are the peroneae, the peroneus brevis, which is the primary everter of the foot, inserting into the base of the fifth metatarsal, whereas the peroneus longus, as I had showed before, curves around the lateral side and inserts onto the base of the first metatarsal. In fact, the primary function of the peroneus longus is first metatarsal flexion. Bony anatomy, there are about 26 bones in the foot. They are arranged into two columns, the medial and the lateral. These are two independent columns that can move on each other. They are hinged at the hind foot. This is the medial column, where there is a talus, navicular, cuneiforms, and the first, second, and third rays. And on the lateral side, you have the lateral column, which consists of the calcaneum, cuboid, and the fourth and fifth rays. This is another picture which shows that the lateral column lies inferolaterally and the medial column lies superomedially. Both of them are hinged around the hind foot. This is how the foot is able to adapt to various undulations in the walking surface. Now coming to the most important joint for the purpose of function is the ankle joint. This is not a single joint. It consists of the tibiotalar joint, the subtalar joint, and the transverse tarsal joint. The transverse tarsal joint exists across both columns. There is a medial column transverse tarsal joint and a lateral column transverse tarsal joint. The lateral column, that is the calcaneocuboid joint, can actually lock and unlock. If it unlocks, there will be a movement over here which is a midfoot break. So that helps to cushion the foot when it is walking. Whereas the medial column has no such locking mechanism. And that is why the plantar fascia is stronger on the medial side. It is placed across to the medial side. Now having seen all of this and the lie of the tendons, to make sense of it, we need two main joint axes. One is the subtalar axis and the other is the ankle joint axis. Any tendon at the level of the ankle that lies anterior to the ankle axis will act as a dorsiflexor. And any tendon that lies posterior to it will act as a plantar flexor. The most important plantar flexor is the Achilles tendon. All of the others are secondary plantar flexors. And if you take the subtalar joint, any tendon that lies medial to it, including the Achilles tendon, is a strong inverter. Whereas any tendon that lies lateral to it is a strong everter. So the peroneae are everters and the EDL and EHL are everters. So that is why when you do a transmetatarsal amputation, you lose the EHL and EDL and the stump goes into slight inversion and you always get an ulcer on the tip of the stump. So the basic movements are dorsiflexion and plantar flexion, inversion and eversion, and abduction and adduction. But often they don't occur alone. They occur as composite movements called supination and pronation. Pronation is where the great toe side goes down and supination is where the great toe side goes up. So coming to human gait mechanics, a gait cycle is defined as one heel strike to the next heel strike of the same foot. It is called a stride. Whereas a step is one heel strike of one foot to the next heel strike of the other foot. That is a step. Okay, so the gait is a bipedal. Humans are the only obligate bipedals in the entire animal kingdom. It is biphasic. There is a stance phase where the foot is on the ground and there is a swing phase when the foot is off the ground. And it is a forward propulsion of the center of mass of the human body. This defines gait. The center of mass is around the pelvis. It is like a controlled fall where the other foot goes and stops the fall. It is designed to occur with least expenditure of energy and occurs with rhythmical reciprocal bursts of flexor and extensor muscle activity. So talking about muscle activity, we must also know the various types of contraction. It can be an isotonic contraction which can further be divided into a concentric contraction where the muscle shortens when it contracts, or an eccentric contraction where the muscle lengthens while still contracting. Or it can be an isometric contraction where the tone changes with time. So coming back to the phases of gait, as we told, it is biphasic. There is a stance phase and there is a swing phase where the foot is off the ground and where the foot is on the ground. Whereas when you compare that with running, if you see in stance, there is a period of double limb support. Both the limbs are on the ground. In running, there is no period of double limb support. Whereas it is replaced by float, where both the feet are off the ground. So this is the basic difference between walking and running. So now further, when we are all interested in the stance phase, because that is where all the pressure of the ground acts on the foot and causes ulcers. So to understand it better, you can actually divide the stance phase further into smaller periods called first, second and third rockers. So taking that pictorially, the foot hits the ground as a heel strike and then rocks on the heel, and this is called the heel rocker. So the foot is in dorsiflex position. There is an eccentric contraction of the anterior muscles, slowly lowering the forefoot onto the ground. So this is a heel rocker. So now the foot goes into plantar flexion. So it was in dorsiflexion, it has gone down to plantar flexion. The next step is, it begins with plantar flexion. The tibia is going to rock on the fixed foot. So this is called a tibial rocker phase. So this is where the pelvis moves forward and the forefoot becomes the hind foot. That is, The foot from front of the pelvis goes to the back of the pelvis, and there is an extreme dorsiflexion here. In this extreme dorsiflexion, all of the kinetic energy is stored as potential energy in the Achilles tendon, as elastic forces. So once this force ends, what happens? The elastic recoil starts off the heel raise, and this pivots on the metatarso-phalangeal joint. That is why this phase is called the metatarso-phalangeal rocker. Here the foot from extreme dorsiflexion again goes into extreme plantar flexion. Here there is an active contraction of the posterior group of muscles which acts through the Achilles tendon. It starts off with an elastic recoil, but then continues through an active contraction of the triceps soleus. That is soleus and gastrocnemius. Another very important mechanism that we must know is the windlass mechanism. So during this phase, metatarso-phalangeal rocker phase, you'll notice that this loose bag of bones is able to bear the entire load of the body. So how does this stabilization of this arch occur? This arch occurs because on the lateral side there is a bony locking mechanism, whereas on the medial side the soft tissues are inserted in such a way that it is like a bow and arrow. So once the soft tissues are stretched out, it stabilizes the arch there. So this is called a windlass mechanism. It is very important to stabilize the medial column. So summarizing the stance phase, it is about 60% of the gait cycle. The foot starts off as a supple shock absorber in pronated foot. Then the hind foot inverts, the transverse tarsal joint locks, and the foot becomes a rigid lever. So it can actually push the entire body weight off the ground. So talking about stance, you also need to see what is the normal stance of the patient to know if there is any problem, such as a neutral stance is the normal stance where the tibia is in line with the calcaneus. This causes equal distribution of weight between the medial and lateral columns, but sometimes there is a abnormal stance where you will notice that the calcaneum is offline to the tibia. So here what happens is most of the load is in the medial side. So once the hind foot goes into eversion, the transverse tarsal joint unlocks. So that means the midfoot becomes unstable, leading to a flat foot. So it is like a link rod mechanism. So hind foot problems will affect the forefoot. So whenever you have a foot like this and you have forefoot problems, without correcting this, whatever surgery you do here is bound to fail. Or you can have an inverted hind foot with a permanently locked transverse tarsal joint, leading to a very stiff foot. So here this is usually seen in meningomyelocele and clubfoot patients. So once they lose their sensation, they will start to develop ulcers. So we talked about the foot being converted into a rigid lever. So what is a lever system? A lever system is a simple machine. A simple machine is where you put in one force and get out one output, one input to one output. It can be a magnified output or it can be a reduced output. So here a lever consists of a fulcrum and a rigid beam. The word rigid is very important. The distance from the fulcrum to the effort is called the effort arm. The distance from the fulcrum to the load is called the load arm. So the efficiency of any lever is directly proportional to the effort arm. If the length of the effort arm increases, the efficiency increases, and inversely proportional to the load arm. So if the load arm increases, the lever will become less efficient. Based on where the fulcrum is placed and what is in the middle, levers can be divided into three. Our entire body is made up of one of these three types of levers. Every movement in the body depends on this lever mechanism. For example, if the fulcrum is in the center, it is a class 1 lever. If the load is in the center, the fulcrum is on one side and the effort is on the other side, it is a class 2 lever. This is also an efficient lever because the effort arm is longer than the load arm. Or if the effort is in the middle, it is a class 3 lever. You will notice that this is an inefficient lever. So the fulcrum, load arm is longer than the effort arm. So the foot functions as a class 1 lever in early stance to a class 2 lever in late stance. So for normal mechanics of the foot, you need good joint mobility, coordinated reciprocal muscle function, and structural integrity. Thank you.
Thank you, Dr. Madhu Perisami. Excellent talk. And may I call upon the next speaker, Dr. M.G. Yuvraj.
Good morning. First, I will say thanks to Dr. Shanmugam and DAISICON team for giving me this opportunity that to talk on diabetic foot. Previous speaker, Dr. Madhu, has had an excellent talk on the architecture. Now I am going to discuss about some practical aspect, what is happening in the clinics. My topic is, see, early detection of foot at risk. The word is early. Most of the diabetics are educated about the complications of diabetes, like hypertension, heart, kidney, and now we have taken exopathy also, now it's coming. But nobody, I think less number of diabetics are having knowledge about the awareness about the diabetic foot. You see in the hall also previously, sexopathy, hall was full. Now, hall is empty. That shows the interest of the doctors. No doctors are willing to see the feet. It's a very, very important complications of the diabetic foot and the expensive complications also. That's why, how to prevent it? I am going to show some of my own clinical experience, what is happening in the foot diabetic clinics. It will be definitely useful for the primary care physicians in the practice. So this is the thing, proverb, பாம்பு கடித்து பிழைத்தவரும் உண்டு, செருப்பு கடித்து செத்தவரும் உண்டு. This is a proverb we used to talk with the patients. The prevalence, we all know that 25% of the diabetics are going for a diabetic foot ulcer and 30% repeated admission. The burden of diabetic foot disease is ranked in the top 10 of all medical conditions. Each and every 30 seconds, someone loses a limb. In diabetes, most of these amputations are very important, are preventable of patients and diagnose and get proper medical care sooner. The prompt referral and prevent foot attack. Dr. Madhu will be knowing that the expense of diabetic foot, so many cases, so many expensive, lifelong, most of the comes to the hospital, the lot of money after going for no money, like Moses stay near no more, no urine, no money, like that. Prompt referral and prevent foot attack. This thing is discussed by Madhu, but each foot is made up of 28 bones, nutshell, 33 joints, 19 muscles, tendons, 100 of ligaments. They provide support, balance and mobility, amazing part. But most neglected part in our life is lifelong weight bearing center. This is very, very important. The tip of the iceberg. We can compare the diabetic with the tip of the iceberg. The poor glycemic control, vascular disease, all pathies, neuropathy, infection, wound healing. That's why most of the patient has to say, sir, sir. That pun is different. This diabetic foot is different. The complication of diabetic foot, this patient Sivakumar, can see he came with the fever, not with the diabetic foot. He came with the fever. Can you see anybody what is happening with him? He is fit. You can see his foot, the fifth toe, somewhat, some discoloration there. His fever, HbA1c 10%. This is the common scenario, regular practice. The dorsum side of the foot, what happened now? We amputated. That fifth toe was amputated, wound development done. So he cannot go for any foot or any jobless for 2 years. This is happening with that. So we have to prevent that. So this patient, this story, he came after 3 years, not for that wound. He came with another foot, with the reviewed after 3, with the complaints of right foot gangrene, right grade 2 gangrene. So it's neglected foot. So diabetes mellitus is associated with the more than half of all non-traumatic lower limb amputations. Major pathophysiologicals, ischemia, neuropathy, infection, wound healing factors, they operate concurrently and sequentially and enhancing the amputation more than 15-fold in diabetic patients. This is the nutshell of the pathogenesis of diabetic foot. Insulin resistance, vascular disease, arterial hemorrhagic, neuropathy, infection, all operate. The most of the patient come to us with comes to the amputation. So why I am discussing about the case, you will be understand. Early detection. Mr. Kannayan, this patient also is a chronic smoker, came with the gangrene of the third toe. The enthusiastic surgeons will go for immediate amputation. Immediate gangrene. See his left toe, second and third toe are already amputated. What happened? You have to see the simple arterial Doppler or arteriography. What it says and say CT angiogram, total occlusion of the right femoral artery. So this is very, very important. CT angiogram shown. So then after that only this patient gone for femoral angiography, then patient for a poster for amputation. Second and third toe. So before going amputation, please do angiogram and vascular disease. So common Chapel induced ulcer. This patient came with the ulcer in the great toe. See Chapel, we have to see all the Chapel. This patient got a hole in the great toe. Due to neuropathic foot, he cannot find the sensation. Then ulcer came, fever came, then he admitted. So next time going for a 3-minute foot examination as a physician angle. 3-minute foot examination, by following this, first minute you take history. Second minute look for a physical examination, then teach. I am going to display one video for 5 minutes. Kindly watch it very carefully because it will not, I am going to start, cannot stop that. Kindly watch it very carefully, which will be very, very useful in your practice from tomorrow itself. By 1 minute you can judge whether this patient is going for a diabetic foot or amputation. So, how to do a 3-minute? This Dr. Madhu showed first the gait analysis, how he walks in the feet. Then you ask full history, whether it's a smoker or heart attack, previous history of any amputation. Everything has to be. By taking history itself, we can diagnose.
Any amputation, any family history, hypertension.
So, history is very, very important. This is 1 minute.
Has to be examined.
Then you look for the total color of the skin color, dermatological examination, hair growth, very important. Any shiny skin, dermatological examination. Then temperature and swelling. I have not used gloves because I have to see the temperature. Temperature, any swelling. Then you see any callus, fissures, interdigital space. Posterior aspect of the feet has to be seen and examined. Any fissure is there. Nails, very, very important. Examine the nail structure, any fungus part is there. Interdigital space, most neglected part. Have to see interdigital space. Then go for a pulses, dorsalis pedis pulse. I think this will take just on 1 minute. By seeing this, it will take 5 minutes. Dorsalis pedis, then posterior tibialis pedis artery, popliteal artery, and femoral artery, popliteal pulse, femoral pulse. Capillary refilling to save the digit. Very important. This can be taught to our staffs. Cotton wool touch. sympathetic, small fibers test. Then you'll go for a pinprick touch.
Yes.
Whether you ask the patient to close the eyes, whether it's going to feel or not. Then reflexes by 128 HZ
Okay. Loss of
tuning fork.
protective sensation.
The loss of protectism, simple monofilament test.
Simple
Just you touch the filament, ask the patient to close the eyes and just give the pressure to that till the buckle of the toe, the monofilament. Ask the patient to whether he is able to recognize or not. This test has been used for Save the Feet and Keep Walking campaign. Now it is 2.0 is going on. 128 HZ tuning fork test.
can be seen by just
Bony prominence.
ask the patient to close the
Vibrations in, then next Doppler detail by pocket Doppler test. Simple. Same thing you can see the posterior tibialis
tibialis
and dorsalis pedis.
important test
Ankle
the vascular
brachial
deformity.
test.
The ankle brachial test.
Very important. Then biothissimeter test. Vibration test. All weight bearing center. Hip switch touch test is a simple test by using a single toe, with the finger touching the first, third and fifth toes. Ask the patient to close whether he is going to recognize or not. Then proprioception tests, joint mobility, what previous speaker Dr. Madhu has displayed about the joint mobility. Fire is very simple. Ask the patient to walk in the fire is bed, get the pressure, and we can go for customized footwear to offload the callus. Each foot has to be examined, whether any pin prick or stabler is there. Self-examination of the mirror is very, very important for the patient. We are seeing the face. Ask the patient to examine regularly. After this full examination, we have found a simple fissure. We can prevent fissure, callus, ingrowing toenail. These are the things by taking history. Paranoia, fungus nail, very dangerous. These things are tip of the rat bite. Mostly come. Frequent case. Hand bite, toe ring, nail cutting by blade, clawed ankle due to the tight shoes. Most of the patients go for acupuncture, shoe bite, foot deformity, charcot foot, and the neglected foot, biothissimeter, harassment. You can see the both pressure, Varman kapam, Mugampol. So, the foot of each patient has to be examined before leaving the consultation room. Evaluation and treatment needs detailed history and non-invasive tests. So, these are all the foot camps we used to conduct in our place to get the raise awareness about the diabetic foot and prevention. So, Varman kapam, Mugampol kalgali paramarikka vendum. Adequate emphasis must be laid to advise the patient to examine the feet daily. So, this is the RSD Save the Feet and Keep Walking campaign. Dr. Vijay Viswanathan, under the guidance of Vijay Viswanathan, in 2022 we have done 10,000 doctors across the country, 35,000 patients have screened by using the monofilament test. You see, in which Tamil Nadu stood first. And total country, Tamil Nadu took first. 20,970 patients. So you see, in our center also in the 5th position. So, love your feet and prevent amputation. These are the thing. 2000 RSSDA, Save the Feet and Keep Walking. This is published in BMJ journal. What it says, save the feet and keep walking campaign, 1/4 of the people with diabetic were have high risk food. So we have to prevent the high risk food, and regular screening of people with diabetes is needed. So prompt referral to diabetic foot specialist is advised. Finally, யாகாவா ராயினும் கால் காக்க சர்க்கரையில் கால் காக்க காவாக்கள் மருத்துவர் காலிழக்கப்பட்டு தீயன்றியப்பட்ட புண்ணு மாறது குருதிமிகு சர்க்கரை. This is our Professor Dr. Sundaram Thiruvalur. With this, I finish my small talk. This will be very useful for all physicians, physicians, doctors everywhere. Thank you.
Thank you, sir, for the simple but wonderful talk. Next, we call upon Dr. Manoj Shah for speaking on foot ulcers, evaluation and classification.
Thank you, sir. And I would like to thank the organizers for this wonderful opportunity. As sir already pointed out that yes, diabetic foot ulcer becomes an important aspect when we are treating our patients. And 1/3 of diabetic patients will land up with some sort of foot ulcers in their lifetime. So to say the fact that is one of the costliest costliest complication for diabetes, because it can land up not only with mortality, morbidity for the patient, but also it will incur healthcare cost burden for the patient, and also the quality of life of the patient is becoming poor. Okay, so ideally the early prevention detection we will be able to preserve the limb in the long term. So my talk is just to highlight on foot ulcers, the evaluation and the classification aspect. And it is an honor to be talking to you in front of my guru itself, Dr. Sandhanam sir. So, thank you. So what is the scope of the problem? Is it very common? Yes. If you see, diabetic foot ulcer affects around 19 to 34% of our diabetic population, high recurrence rate, higher risk of amputation, and also mortality will increase by 50 to 70% within 5 years. Also, the healthcare cost becomes on the higher side. Current trends, if you see, the risk of amputation has been increased by 50% in the recent times. And the recent article published, it shows you that the prevalence of diabetic foot ulcers overall you see is 6.2%. Highest in the eastern part of India, which is 9.5, and South India is not lagging behind, is 7.4%. Okay. So what is the aim of this talk? Is to have a clinical evaluation so that we can systematically assess the patient's data, symptoms and the test results, so that we can make a diagnosis and the treatment at the early stage itself. And classification is very important because you can assess the disease severity, complexity, and also you will be able to tailor the treatment and a proper care planning. So just a clinical history, a hypothetical case of a 58 years old man, poorly controlled type 2 diabetes, noticed a small blister after walking with the type 2 shoes, like how sir has presented, thinking it was a minor infection. Later the blister progressed over the period of weeks and developed ulcer, and ulcer got deepest. I am sure we would have seen these cases multiple times in our clinic. So as sir said, we have got 3 pillars of diabetic foot ulcers. Peripheral neuropathy, because the patient will have sensory neuropathy, motor neuropathy, and also autonomic neuropathy leading to foot ulcers. Then peripheral artery disease. What happened with PAD? The risk of infections will be high, and also the quality of there will be poor wound healing also. And then trauma, because of any footwear or pressures, the patient will land up with trauma. Initially the trauma is mild. Because of the neuropathy, the patient will not be able to see it early. And then when the patient comes to the clinic, they come with a full-blown ulcers. Okay. So clinical evaluation, just do a good proper history taking, look into the duration of diabetes and the what are the comorbidities with the patients, look into the current medications and the glycemic control of the patients. Then look into the symptoms of neuropathy, like as sir said, look into the numbness, tingling, pain, look into the vascular symptoms, whether the patient has got claudication pain or rest pain. And then take a history of trauma and smoking also. And if there is any history of previous ulcers or amputation, should be taken into consideration. General inspection, I think it was dealt in detail, but just look into the ambulation, look into the gait of the patient, examine the footwear of the patient, and bilaterally look into the inspection of the patient, especially the interdigital foot spaces, and document. I think in today's era, it is always best to document all the details of the patient and the foot also. Okay. So this is how you perform a sensory neuropathy test. So you have got monofilament. I am sure everybody have seen this, okay. So 3 tools are there. You do a monofilament test, you can do with a tuning fork test, which is just 128 Hertz tuning fork test, and Ipswich test. So if there is a presence or absence of protective sensation, then you go to the tuning fork test and look into the presence or absence of the vibration test, and after that you look into the touch sensation. So with the monofilament test, what you are doing, you are looking at the small and medium fibers of type A, beta fibers we are looking into, and with the tuning fork test you are looking into the large fibers, usually type alpha and A, alpha and beta, okay. So as sir pointed out, we need to put at the hallux, metatarsal and fifth metatarsal. Out of 3, if any 2 is absent, then you tell the patient as LOPS, which is loss of protective sensation. Similarly for the vibration also, you look into the metatarsal heads or the great toe. If the great toe is absent, then you look at the next toe. Again, out of 3 position, if 2 is absent, you tell them as a sensory neuropathy, like tuning fork is absent, okay. And then again for the speech test also, you look into the light touch, and if it's out of 3 point, if 2 is absent, you tell the patient has got test as negative, okay. So this is how you perform sensory neuropathy test, okay. And then how you perform the vascular test. Sir had a video on that. So you palpate the foot. Even if if you see the foot pulse positive, you look into the Doppler test also. Sometimes you may feel the pulse, but may not be strong enough. So you will have to look into the Doppler also. Look into the waveform of the Doppler, and then look into ankle brachial index and also toe brachial index. So if it is triphasic Doppler waves are there, if the waves are triphasic, then is normal, or ABI more than 0.9 to 1.3 is normal. Toe brachial index is more than 0.75, you say it is normal, so less likely to be having a peripheral artery disease. But if you have an abnormal value, then probably you will have to refer to a vascular surgeon immediately, okay. And severe ischemia, if you see that the ankle pressure is less than 50 milligram per mercury, and our TBI, which is toe brachial index, is less than 0.5, or the toe pressure index is less than 30 mm, then you need to have an urgent referral to the vascular surgeon. So we have done with the first 2 pillars, your neuropathy assessment and the vascular assessment. What is the role of imaging? What is the role of imaging here? So mostly we start with the radiograph. So basically you want to just look into all the deep wounds or infected wounds. You will see visible changes only after 10 to 14 days. Less sensitive for osteomyelitis. So next what we do, you do a MRI. MRI becomes a gold standard because you look into the soft tissues, and morely you will pick up more of a osteomyelitis for the patient. You also can look into deep seated abscess, or if you are planning for a surgical intervention. Advantage, if you see, it has got 90% sensitivity and specificity, and excellent for the soft tissues details. Nuclear medicine, if you look, very limited options for that, but only when you have got prosthetic joint infections, then probably you can look into the nuclear medicine study also. Now when you document a patient for ulcer, so I just put a mnemonic as blessed. You note the base of the ulcer, whether it is granulation, slough or necrosis. Look into the location, and exactly you can point out the location of the ulcer. Edges, whether it is well defined or undermined edged. Size of the ulcer, length, breadth and also depth of the ulcer should be noted. Surrounding skin, whether it is erythematous, induration or warmth. Exudate, what is the amount of exudate, you can just roughly write the amount of exudate, color and order also, and depth of the ulcer, whether it is superficial ulcer, superficial structures or a deep structures also are involved with that. And then you do a probe to bone test to pick out osteomyelitis, sinus tract, and also look into signs of infection, whether it is purulence, the pungent smelling pus, or if there is increased pain, or if there are any systemic symptoms. So you will need to document all this data into your case sheet. Now let's look into the other part. We have finished the evaluation. Now let's look into the classifications. Okay. So classification, traditionally we have got Wagner's classification, where you have got 5 stages. So first stage is a pre-ulcerative stage without any area of dominant ulcer, like sir showed you one picture where you cannot see the ulcer also. Okay, so that is the first stage. Second stage becomes a superficial ulcers, not going into the deep tissue, just in the dermal tissues. Okay. And then second stage becomes your deep ulcers, but not to the point of osteomyelitis or deep tissues. Then you have got deep ulcers where you can have a presence of abscess or osteomyelitis for the patient, or in joint they may have sepsis there. In stage 4, you look into local gangrene. It can be either at the toe level or at the heel level. And stage 5, you will look into the whole foot will go for gangrene. Okay. Most commonly, if you see, it is a grade 2 which patients come to our clinic, and when it is grade 4 and 5, you require a surgery. So higher the grade they go, the risk of amputation and surgery becomes on the higher side. Okay. Then another classification comes is University of Texas. So here you have got grade and staging. So grade is basically 0, 1, 2, 3, where 1 is a pre-ulcerative lesion without any skin break. 0. And then stage grade 1 becomes a superficial wound without any penetration. Your grade 2 becomes a wound penetration up to tendon or the capsule, and in grade 3 you have got it extends up to your joints, bone and joints. Okay. And then whether it is infected or with ischemia comes with stage B and C, and stage D is with infection and ischemia both. With the same, at the same grade you can have both also. Okay. Why it is very important? Because again it will help you to quantify the risk of amputations, and it will take into ischemia and infection into consideration. It is more specific for treatment guidelines. Okay. Then you have got Sinbad classification. Basically when you are referring the patient to another hospital, or when you are communicating with a healthcare system, then probably this system of classification will be really helpful. Is a rapid assessment tool, and where you look into site, ischemia, neuropathy, bacterial infection, the area of the ulcer and the depth of the ulcer. So you will put a score 0 or 1. So if it is a 4-foot ulcer, or if the pulse is seen, if you have got protective sensation, no bacterial infection, size of the ulcer is less than 1 centimeter, and the depth is just superficial, skin to subcutaneous tissue, you will score them as 0. Where if the site goes to midfoot or hindfoot, pulses are less, your protective sensations are lost, there are some amount of bacterial infections, size of the infection of the ulcer is more than 1 centimeter, or if the depth of the ulcer goes to the muscle, tendon, or even the deeper tissues, then you will score them as 1. You will score them 1 for each of the parameters. And if the score comes to 0 to 2 part, then you can safely say that the patient has got lower risk of amputation, better prognosis, and likely to respond to standard treatment. But if the score is more than 3, then probably you have a higher risk of complication, amputation, and you need to be more aggressive in the beginning itself. And then another classification comes is WIFI classification, which you take into wound, ischemia, and also foot infection into category. Again, you have got 3 grade here, 3 scoring here. For wound, if you see, there's 3, for ischemia 3, and for foot ulcers also 3. So for wound, you see, it is 0 is without any, with no obvious ulcers. If it's 1, it is small ulcers and without any gangrene. 2 is the deep ulcers or some amount of gangrene is seen, and 3 if it is extensive ulcers or extensive gangrene. Look into ischemia again, you have got 3 up to 3 grades. 0 if the pressure is normal, toe pressure is more than 60, less than 30, less than 40, 39 to 40, 40 to 59 is stage 1, and then 30 to 39 it becomes stage 2, and less than 30 it is stage 3. Okay. Similarly for foot infection also, you have got if it is non-infected it is 0, and if it is mild infection it is stage 1, moderate stage 2, and if it is severe infection it is stage 3. So stage 1 usually it will require less chances of vascularization, and the healing, if you just put a proper offloading and wound care, the healing will be good. And as you go off the stage, the risk of amputation is high. So once you put the score, you have got this very low risk, medium risk, and high risk. So based on the plot, you can plan how aggressive you have to go for the treatment. Okay. Then superior protection for healing and amputation, and proper revascularization plan you can do. And then you have got this IDSA classification, and this is just look into the infection part. So whether this, you look into the severity of infection, whether it's mild infection, moderate infection or severe infection. So mild infection, you should have at least, out of this 5, you should have at least 2. So local swelling, induration, the arrhythmia should be more than 5 centimeters, local tenderness, increased warmth or purulent discharge. You can treat them with an oral agent. If the patient has got moderate infection, how do you tell that? If the local infection is, erythema is more than 2 centimeter, or if deeper structures are involved, then you can either treat them with oral agents or IV agent, parenteral agent. If it's severe infection, systemic features are there, then probably you go into a parenteral agents. Okay. So this is how you do a clinical framework for low risk patient, that is no loss of protective sensations or no peripheral artery disease. You can examine the foot yearly once and always look into the symptoms of LOPS and PAD. And then low risk patient with some amount of LOPS or PAD, then probably every 6 months you should be looking into all the investigations. For moderate risk, if the patient has got LOPS plus PAD or with foot deformity, then this patient comes under moderate risk. High risk is when the patient has got history of ulcers or minor amputations or patient with end stage renal disease. Probably for them you have to do all the assessment once in 3 months. So for this patient, it was LOPS was positive, signs of infections was there, probe to bone test was positive, grade 2 ulcers, so mild ulcers. So probably you can avoid amputation, good healing process, and systemic antibiotics is more than enough for the patients. So again, if the patient has got stable ulcers, healing ulcers, routine follow-up can be, for them the risk assessment is less. But if the patient has got some systemic infection signs, exposed bones and tissues, spreading cellulitis, ischemia, then you need to have an emergency assessment for the patient. Urgent assessment, if the patient has newly developed ulcers, there is sudden sign of infections or the pain is on the higher side, then probably this patient needs an urgent assessment. When do you refer a patient? When the Wagner's grade is more than 3 or WI5 is more than 2, then probably refer the patient immediately. If the Sinbad score is more than 3, refer the patient. Probe to bone test positive, refer the patient. Or if the healing is not adequate for more than 4 weeks, then refer the patient to the higher center.
Dr. Manoj?
Yes, sir. Just the 2 slides. Okay, so emerging condition, if you see, because no proper systems are defined here, and comorbidities and social determinants are not taken here. So emerging approach, you will see AI coming into picture. We can look into biomarkers, and also sometimes medicine compatibility assessment also may be useful. Just to end up, so we have to do a proper evaluation, and documentation is the key in today's time. Wagner's classification looked at the depth based. Grade 4 and 5 needs urgent surgery, and you should refer the patient. Grade 2 is one which is most common. University of Texas, it looks into ischemia and infections and looks into better predictive value. Sinbad system is very, very simple, rapid, validated for communication with your colleagues. WIFI's classification is focused on the limb which is at threat and vascular planning. And IDSA classification will help you to guide into antibiotic duration and hospitalization criteria. So just to say, classification will just guide you, but does not replace your clinical judgment. So patient-centric care and multidisciplinary approach remains fundamental aspect for the proper optimum outcomes. So thank you.
Thank you, Dr. Manoj. Next, I invite Dr. Ilaya Kumar to speak upon the vascular assessments and interventions in the diabetic foot.
Good afternoon, respected chairpersons, senior faculties, Dr. Selva Pandian sir, and fellow speakers and my dear delegates. And it's indeed a pleasure to be here, and I thank the organizing committee, particularly Dr. Sharmagam sir, for giving me this opportunity to present this topic. I have no disclosures. Only thing that my previous 2 speakers spoke about my topic and making my job easy. So this very much will be repeated here. Prevalence of PAD in diabetic is 2-fold higher than the non-diabetic patients, and PAD, that is peripheral arterial disease, contributes to around 50% of the foot ulcers, and in combination with neuropathy is the cause for 45% of them. and lower extremity amputation in diabetic occurs every 20 seconds worldwide. That works out around 16.8 million amputations worldwide. That's a scary statistic indeed. At MMC, we did a prevalence study of asymptomatic PAD in patients with the diabetes mellitus. We just screened those patients who are coming to the diabetic OP. There's supposed to be around 2,500 patients. We have not finished the study, we extended it, and we took the ankle brachial index and the toe brachial index, ABI less than 0.9 and TBI less than 0.7 as criteria for PAD. And we found to our surprise around 15.8% of these patients had asymptomatic PAD, and particularly in the age group between 32.9%, and this is very, very worrying. So why does these diabetic patients are prone to develop vascular occlusion is due to this RAGE pathway which you have to be familiar with. So this RAGE pathway initiates certain inflammatory pathways and cytokines which in a way is similar to the formation of atheroma. Only problem here is this atheroma formation in diabetes occurs 20 to 30 years earlier than your conventional atherosclerosis. So we have to catch them early. So what is the role of vascular assessment in these patients? One is to see if there's any significant vascular occlusion or not, where is the occlusion, how severe it is, will procedures, minor procedures, ulcers heal by themselves, or do you need to plan for any interventions? Most of this has been dealt by my previous two speakers, nothing much. Claudication, patient may, that's the early symptom, patient may complain of pain on walking for a certain distance, and he may stop and then pain disappears, continues to walk. And depending upon the level of the occlusion, it may be in the calf, thigh or gluteal, and it may worsen to rest pain. Sometimes patient may present with ulcers, gangrene, or sometimes non-healing ulcers or stumps. Comorbid conditions has to be inquired into because the multi-level blocks may be there. History of CAD, CVA, and nephropathy should be included. ED we have already dealt with in last session. Tobacco usage should also be inquired into. And any previous procedures that has been done to the patient has to be properly inquired. The problems here is, of course, due to diabetes, there's absence of classical symptoms. Claudication, rest pain may not be there. So due to this neuropathy, both peripheral and autonomic, so patient present to us pretty late. Already Sir has beautifully shown us how to palpate for the dorsalis pedis and posterior tibial, very important. 1 minute examination. Absence of pulses in diabetes itself is a criteria for critical limb ischemia and needs further evaluation. Please don't forget that. Along with whatever Sir has told, skin, warm temperature ulcer, ABI, and certain thing. Distribution of ischemic ulcers most commonly are found in the toe and may be precipitated by ill-fitting footwear, and particularly in our country in the sole, because most of these patients go for girivalam or pilgrimages. They walk barefoot on a hot sun. So that it may precipitate a gangrene and may unmask the peripheral arterial disease that is underneath. Ankle brachial index, very useful clinical tool, has been discussed. More than one is normal, less than 0.9 it's PAD, but however in diabetes due to calcification we sometimes have falsely elevated pressure, so toe pressures are more important because the toe vessels are relatively spare in diabetes, and Mass mentions a TBI less than 0.7 is abnormal. And transcutaneous oxygen probe is also very important in assessing these patients, which is an indirect marker for perfusion underneath. So normal is around 50 to 70, but patient with ischemia, they may have less than 40 or less than 30, which may be an indicator for a critical limb ischemia underneath. This is a device we use in MMC. It's a screening tool basically with the cuffs and the sensors, including the toe. So at the touch of a button, you can get an ABI, TBI, you can connect the ECG and look for any signs of CAD also. And this is a very good review article in the JAMA published recently by David Armstrong and Andrew Bolton, two people whom I cherish most, my association with them in 2 decades back. And this is again a non-invasive Doppler evaluation particularly patients who come to with claudication. It gives you a baseline value and also helps you to screen these patients every 6 months, and also for post-intervention surveillance, a Doppler is very useful. Angiogram you do only when you are planning to intervene. That means patient already has a gangrene, severe wrist pain, you need to intervene, then you go for an angiogram. Not all patients or claudicants need an angiogram. So it can be CT based or MRI based, and your gold standard is a digital subtraction angiography. And the distribution in diabetes, the vessel involvement is mostly infrainguinal, mostly below the knee, compared to a conventional atherosclerosis where the major vessels may be involved. So the angio findings are, majority are below knee, infrapopliteal, long segment occlusions compared to the opposite side, and also relative sparing of the peroneal artery. It's not spare, but less involved than the peroneal, less than involved than the other tibial vessels. Occlusion of one or more tibial vessels can be there. Pedal vasculature is spared in around 88%, so ideally we can do a bypass even up to the pedal vessels. This shows, the angiogram shows very severe distal disease, very much the pattern in diabetes mellitus. Non-contrast MRI and CO2 angiogram can be used, particularly in diabetic patient with the raised renal parameters where you're worried that may precipitate a renal failure. We have interventions based on CO2 angiogram. Wi-Fi score already been mentioned by a previous speaker. Very, very important, and it was issued by the Society for Vascular Surgery. And the thing is, Wi-Fi is more a predictor of wound healing. So stage 1 Wi-Fi have higher wound healing and limb salvage compared to your stage 4 Wi-Fi, where the wound healing and probability of amputation is very high, and these are the patients very much who need a vascular interventions to save the limb. And majority of our patients comes to the stage 4 Wi-Fi with deep infected plantar ulcer. Limb salvage in these patients are very, very challenging. So what is the management? Includes medical and surgical. Medical, you plan to decrease the progression of the disease, increase the blood flow and relief of pain and optimization of the comorbids. You can reduce the progression of the disease by asking them to quit smoking, treat the predisposing factors, and food care has already been, will all be alluded to. And increase the blood flow by exercise. Walking is the best exercise we recommend, because walking, it improves the collateral circulation due to what is known as an ischemic preconditioning. So patient who is able to walk for 200 meters, 100 meters before, if he keeps on walking, it may improve to 500, 1 kilometer, etc., and doesn't need any intervention. Drugs may help, like antiplatelets. Celestrol is again class 1A recommendations for patients with claudications. Percentin, Trental, in some cases we use. Relief of pain is important, particularly patients with critical limb ischemia, gangrene. They may need NSAIDs, opiates, epidural analgesics, and nerve blocks. Suppose patient have deep-seated abscess, that may be the cause of the pain, which needs to be drained and treatment with appropriate antibiotics. This graph very much sums up the role of the vascular surgeon. If the perfusion is good, the vascular surgeon doesn't have much of a role. It's only the primary podiatrist or the plastic surgeon who takes over. Only if the flow is inadequate, then it's a prerogative of the vascular surgeon to improve the blood flow. So, interventions again depends upon what is the comorbids and lesion characteristics. If the small segment stenosis or occlusion, predominantly we go for endovascular option like angioplasty and stenting. It's a long segment occlusion, then open bypasses is the choice. But sometimes if the patient is a poor risk for open surgery, then we may consider other options. Whatever the thing, whether a surgery or endovascular, the objective of revascularization is to provide an inline flow to the foot. Sometimes you need to treat more than one segment and should be angiosome based. We have around 6 angiosomes in the foot based on the 3 arteries, anteritibial, posterior, and peroneal. Suppose we have an ulcer in the toes, it comes under the AT tributary. It is better to open up the AT. If it is in the heel, it's a PT territory, that is the posterior tibial territory. We need to revascularize the posterior tibial. The aim is to provide an pulsatile flow going into the foot. So what are the indications for surgery in our endovascular era is young fit patients, failed endovascular procedures, small size artery, particularly in Asian population, major tissue loss, complex lesion, and in a country like ours, cost effectiveness is important. I do both endovascular as well as open, but I find there are durable, long-lasting results with open surgery compared to our endovascular approach, because endovascular sometimes is not patterned beyond 1 year or 2 years. You need to call them and do them back, do the endovascular, which is very, very costly in our country. Some of the series of the patients, this is a 65-year-old gentleman who was riding pillion, kept his foot on the silencer, developed a silencer burn, full-length ulcer, and developed non-healing with critical limb ischemia, severe wrist pain. Angio showed a popliteal block here with the reformation of the posterior tibial. So what we did is a popliteal artery to posterior tibial. We used the saphenous vein graft. So with that, the circulation improved. All you need is a subtotal calcanectomy and excision of the ulcer. This was done some time back. Probably now I would have used a free flap option for this closure of the ulcer. Again, an infected ulcer, ischemic foot, advised amputation somewhere. Angiogram shows a femoral popliteal block. So what I did is a common femoral to proximal popliteal ROC bypass. You can see the difference pre and post procedure. This wound, all it needs is a SSG. So this is how a foot can be salvaged. Peroneal artery, as I said, is more amenable in diabetic, it's bad. So we can do a lot of these peroneal artery bypasses for foot salvage. Even dorsalis pedis up to dorsalis pedis to improve the foot ulcers. Sometimes the plantar artery is the only option for an ischemic wound like this. We can go for a plantar bypass. See the post procedure. We can use some negative VAC therapy and some SSG for foot salvage. Endovascular interventions are increasing. More of angiograms or interventions are being carried on, and bypasses are becoming low these days due to improvements in the hardware and the techniques. But we reserve endovascular procedures for patients who are unfit for surgery, short segment proximal lesions, and hybrid procedures. That is, you do a proximal endovascular and a distal bypass, and as palliative procedures. There's a patient with a SFA block here. You can see this block, and what we have done is, I don't think that we did a stenting, and you can see the wound status clearly. It is improved with just a SSG for cover. So again, a critical ulcer with mid-popliteal block, angioplasty, and after that 2 months is completely healed. Which is best, surgery or endovascular? The best CLI trial published in the NAGM by Fabre et al. Has concluded that in the presence of a great saphenous vein for a bypass, surgery is superior to endovascular therapy. In the absence of a saphenous vein, then both modalities have equal results. So if you have a saphenous vein, go for an open bypass. But there are some patients who have no option critical limb ischemia. That is, you don't have any vessels for bypass. So in this situation, certain experimental therapy can be tried: lumbar sympathectomy, thrombolysis, prostaglandin. Stem cell therapy is also tried. We have tried some patients where we inject allogenic stem cells into the calf muscles. These basically encourage neorevascularization. So we have patient with no options. But after a stem cell, we can have a foot salvage. So the leg is basically served from a major amputation. PRP is also one of the options, and we found that there's a good results in this study. We are continuing this study. Amputation is the last resort and reserved for patients with irreversible ischemia. And the aim of these CMEs and workshop is to prevent situations like this, to prevent unnecessary amputations. And the Society for Vascular Surgery provided the inter-society guidelines. So patient with diabetes and ulcer gangrene, palpate pulses and examine for signs of ischemia, evaluate Doppler ABI, and use Wi-Fi to stratify the amputation risk. Absent pulses, very poor signals, urgent vascular intervention and consultation. If the ABI is normal, all it needs is wound care and treatment of infection. Reassess perfusion if there lack of healing after 4 weeks. And this is MMC data from 10-year data. We have around 1,215 interventions. Open bypass is 60%. Endovascular is around 38%. Below knee, around 400 bypasses. And below knee tibial interventions around 246. Amputation rate is just 17%, so 83% limb salvage, and mortality in 5 years 30% is a grave because of the coexisting morbidities. The take-home message is diabetic foot is an enormous public health problem which needs a multidisciplinary approach. You need a plastic surgeon, podiatrist, vascular surgeon to combat it, And foot amputation can be decreased by timely diagnosis and early intervention. This my one-time idol, Dr. Andrew Bolton. And thanks once again for inviting me for this talk, and I'll take the questions at the end of the session. Thank you. Back here again, this time we'll be talking on small steps, big impact, and simple surgical procedures for diabetic foot ulcers.
Thank you. I purposely left out small steps and simple surgical procedures in the title. It has a cause. Well, let's get on straight to the talk. It's going to be a slightly long talk. I just ask for your forgiveness if I overshoot my time. But I'm sure I'll make it worth it. So, the current recommendations issued by the IWGDF 2019 about surgery was, if all of your offloading failed, they gave you a space that was that small. Moving on to 2023, it became bigger. So surgery is being increasingly recognized as a method of treatment of diabetic foot ulcers. Traditional surgical solutions included flaps and grafts. You can see here, healed well. Another patient with which you have a well-healed ulcer. But then what truly happened afterwards, if you notice, the same ulcer comes back at the end of 2 years. And again here, the same healed ulcer is back. So this situation is often being seen by the referring physician, not by the treating surgeon. So what happens is, once he sees that, he comes to a conclusion there is no clear surgical solution and defers surgery and ultimately leading to amputation. So my job here is to actually share with all our physician colleagues about the modern surgical perspectives that have changed. And what has changed is, we have learned how to minimize recurrence. So why do ulcers occur? Ulcers occur because of a combination of the loss of sensation and biomechanical defects. If one of these two is not present, for example in a polio patient with a biomechanical problem, if his sensation is intact, he will not get an ulcer. But when both are present, focal areas of high pressure develop, particularly because of deformities because of intrinsic neuropathy, which lead to fatigue failure in the tissues, causing calluses, which in turn increase the pressure under the subcallus area by 30%, causing ulcers. So any callus that has turned black means that it is ulcerated. And before you debride such a callus, please tell the patient there's going to be an ulcer underneath, otherwise they'll blame you for the ulcer. We also need to know why ulcers recur, because often our treatment, you cannot treat sensory loss. Sensory loss is going to be persistent. Whereas biomechanical defects, they can be corrected. And this gives us a small window to reduce recurrences. This is the usual presentation in any diabetic foot clinic. There is a gamut of cases. But if you rearrange all of this, you'll notice there is a gradual progression of severity from the left to right. This is encompassed in all classifications. Dr. Manoj Shah has told us in detail about all of this. Maggot and Wagner, the University of Texas and all that. But if you notice one pattern in all of these classifications are descriptive. They're going to tell you this is this, which is very obvious. You seeing the patient is obvious. And they're going to tell you what is the risk of amputation. And that is one thing the patient does not want to hear. No classification will tell you what surgery to do, when to do. So that is why we have developed our own classification using the same parameters, which is a directive classification. So let me describe it in pictures. For example, this is a foot at risk. There is only a callus, there is no wound. There is no vascular problem, there is no Charcot. The same grade 2 ulcer can come back with a wound, but there is no invasive infection. There can be only a contamination or colonization. There is again no Charcot, no vascular problem. Or the same grade 2 ulcer can come with an invasive infection, which can be with or without soft tissue loss. Included in this is early Charcot and early ischemia, where it is still salvageable. Or it can come as a class 4 critical disease, where the grade 2 ulcer can come with a massive sepsis, patient with a life-threatening risk, and you need an urgent amputation to save the life of the patient. Or you can also have major gangrene or extensive Charcot where there is extensive bone loss. So here what we take into account is functional salvage. It's not about salvage alone, whether the patient can actually use that foot to walk after spending few lakh of rupees on that foot. So surgery right now is mostly concentrated to gangrene and amputation, whereas we are trying to shift the curve to the left, where to ulcer and callus. So that is the thought shift that we are trying to make in treatment of diabetic foot ulcers. And we've been doing this for the past decade. But still, at what stage do we get patients? We still get patients, 80% of patients in class 3 and class 4. That is why we have taken the scheme on to the government, because we know that government is the best place where it can spread information throughout the population. And once the government accepts it, people accept it. So now that has led to the Padam Padukapam Tittam. And Tamil Nadu is the only state in the country that has a dedicated diabetic foot program. Interventions in the diabetic foot can also be classified just as we have classified the ulcer. We can also classify interventions into preventive podiatry, surgical offloading, debridement and reconstructive surgery, and major amputation. So let's take for the class 1 foot. It's usually managed in the diabetologist's office by preventive podiatry, including all of these methods. The best thing to have is a customized footwear, where the insole is customized. Insole, the outsole can also be customized. So the outsole is the part of the footwear that is in contact with the ground. The insole is the part of the footwear that is in contact with the foot. So there are two places you can customize that footwear. So the insole and the outsole. The most important insole modifications are the arch support, the transverse metatarsal bar, the heel cup, and scoopings to allow the ulcer to or deformities to be accommodated. But what is the role of surgery in class 1? Nerve surgery has a place in class 1, particularly when there is an onlay of compressive neuropathy on generalized diabetic neuropathy. This can be diagnosed by the presence of a Tinel sign, particularly over areas of nerve compression, where the posterior tibial nerve, usually in the tarsal tunnel, anterior tibial nerve on the dorsum of the foot, and the common peroneal nerve at the fibular neck. Let me give you an example. This was a young juvenile diabetic, came to us with a sudden foot drop. We did a common peroneal tunnel release, and if you see, when we stimulate after the tunnel, there is a good stimulation, whereas when we stimulated before the tunnel, there was hardly any stimulation, meaning that there was a nerve block in that area. So once that was released, the fellow who came to us with this acute foot drop, without any tendon transfer operation, recovered completely. So now moving on to class 2. So what does the guidelines say? A knee-high cast boot, removable or non-removable, is the treatment of choice. Well, that's the treatment of choice for healing the ulcer. But what about the recurrence? But there is another recommendation also. Whenever a patient with diabetes and neuropathic plantar ulcer has an active ulcer, do not use and instruct the patient not to use conventional or standard therapeutic footwear as offloading treatment. I hope you'll notice this point, because the international guidelines itself now say, please do not use MCR footwear, MCP footwear for active ulcers. They are only used for preventing a recurrence of the ulcers. So the method of choice is external offloading by means of a total contact cast, which may not be very acceptable to our population, or internal offloading by surgical offloading. So what is exactly surgical offloading? Surgical offloading, according to the place where the ulcer occurs, there are certain pathomechanics which are very specific to that ulcer. And if you correct that, the ulcer will automatically heal. It is just by redistributing pressure by surgical means. For example, take grade 2 ulcers. Grade 2 ulcers form 30% of all diabetic foot ulcers. It can be either an IP joint ulcer, where it is in the level of the IP joint, or distal to it, which is a subungual ulcer. Both of these have their own specific mechanics. The first MTP joint tightness causes the IP joint ulcer. It is because of the presence of the windlass mechanism. We had seen about it in the earlier talk. It can be released by either just doing a small plantar fascia release, which releases only a small component of the problem. You can do it under local anesthesia, a plantar fasciectomy. It heals the ulcer, but there is a very high chance of recurrence, about 60% chance of recurrence. But the gold standard is a Keller arthroplasty of the first of the PPX of the grade 2, where all of the intrinsic insertions into the grade 2 are removed. So in fact, the windlass mechanism is disrupted. So once you do that, the toe becomes very floppy and can move easily, and the ulcer automatically heals. We have published on this in the Foot and Ankle International. Now coming to the second grade 2 ulcer, which is the tip ulcer, it is because of the intrinsic loss causing a claw or hammer toe deformity where there is a tip to floor contact. Here the action of the FHL is the problem, and you do a simple FHL tenotomy, either open or a closed tenotomy, you will be able to solve the problem. We have also published on this on the Journal of Foot and Ankle Surgery. So minor toe ulcers, again the deformity is the problem causing a tip to floor contact instead of a normal pulp to floor contact. A simple tenotomy of the FDL tendon will lead to healing of the ulcers. All of this can be done in the clinic. The aim is to achieve pulp to floor contact rather than tip to floor contact. Metatarsal head ulcers, otherwise called forefoot ulcers, are mostly due to the equinus contracture. So anytime the Achilles tendon is contracted and the triceps surae is overacting, as I told you, the Achilles tendon acts on the forefoot through the plantar fascia. So overaction of the Achilles tendon will be transmitted to the forefoot. So high pressures on the forefoot will cause metatarsal head ulcers. This can be treated by a gastrocsoleus recession or an Achilles tendon lengthening. This will lead to shifting of the forefoot pressure to the hindfoot. And you'll notice the peak forefoot pressure to hindfoot pressure ratio comes down post-operatively. This can also be combined with distal metatarsal osteotomies as and when needed. First metatarsal head ulcers, if you remember this slide, it is because of peroneal overactivity. Because of neuropathy, the peroneus does not know when to relax. So it keeps on contracting. It is called a peroneal overdrive. When there is a peroneal overdrive, there will be a very high pressure on the first metatarsal head. The answer is the peroneus longus to brevis transfer. So you cut the peroneus longus, you take away the flexion force, but retain the eversion so as to prevent an inverted foot. This can also be assisted by a Jones transfer, which is a form of a claw correction operation. It is a static claw correction operation, but in a very scarred foot, we would prefer to do a first metatarsal osteotomy at the base. We have also published this in the Foot and Ankle International 2 months ago. So plantar midfoot ulcers, again equinus contractures. If the midfoot is stable, it is a forefoot ulcer. If the midfoot becomes unstable, a Charcot collapse can occur, and this can cause a plantar midfoot ulcer. This can be diagnosed by plain radiographs. Any patient walking into the diabetic foot clinic should have a weight-bearing AP and lateral foot x-rays. These are called standard foot views. So what will you see in these lateral views? You must look for the Meary line. So a long axis drawn through the talus must coincide with the long axis of the first metatarsal. If it does not coincide, for example, here you see there is a plantarward inversion or deviation of the long axis of the talus. It means there is an ongoing collapse in the midfoot. So whenever you see this, it needs to be reconstructed. The Meary line needs to be reformed, and that is the only thing that can cure these midfoot ulcers. However, some patients come to you with an old Charcot. You can see that the midfoot and the hindfoot have gone into one separate segment. The forefoot has gone into another segment. A rocker bottom deformity has been formed. When it is malunited and already union has formed here, then all you need to do is an exhaustectomy. You can do that exhaustectomy either through a medial or lateral approach, or sometimes even a central approach, and you will get a well-healed ulcer. Now coming to the heel ulcer. The heel ulcer is because of Achilles tendon loss. The loss of the Achilles tendon function. Overactivity of the Achilles tendon will cause forefoot pressure. Loss of the Achilles tendon function will cause heel ulcers, particularly trophic heel ulcers. So what we have done here is we have just done a grafting. When we sent the patient back, they came back with a recurrence. So that is why we do not advise a partial calcaneectomy. If you put the patient on a pedobaragram, you'll know entire load is only on the heel. That is because the Achilles tendon function is lost. And as I told you, overactive on the forefoot, loss of Achilles tendon on the heel. So this is the pedobaragram, serial pedobaragram of a 13-year-old girl. She came with an undiagnosed Achilles tendon injury because of a fall into a latrine, not recognized, just sutured, limping. When we put her onto a pedobaragram, it is like this. But when you repair it and have serially you find it, it takes 9 months even in a child for forefoot loading to return. So this is when you can transfer the hindfoot load to the forefoot, and that is will cause healing of the ulcers. There are multiple methods of reconstruction of the Achilles tendon, including tendon transfers, and you see the hindfoot load will be transferred to the forefoot. We have also published on this in JPRAS. However, in some patients, the calcaneum will be not enough to do Achilles tendon reconstruction. In such a case, ankle fusion is the only choice to get a rigid foot. So class 3, I'm going to run fast on this. Class 3 is when you have an invasive infection with or without gangrene. The most important operation is a 3-dimensional wound excision. It's not incision and drainage. Incision and drainage never works. Even in an abscess, even in a carbuncle, always do a 3-dimensional wound excision to get fresh bleeding wounds. So you see here a 3-dimensional wound excision. The wound has been completely excised and grafted. You can do local flaps. You can also do free microvascular flaps. We have just given the paper for publication on free microvascular flaps. Ischemic ulcers, Dr. Ilay Kumar has spoken well. Now coming to class 4. These are the feet that you must amputate. Do a major amputation. Please do not attempt to salvage these feet. It is very important to recognize stage 4 because of the threat to life and also the futility of salvage. So it helps to arrive at a quick decision on major amputation and minimizes the wastage of both limited patient and public healthcare resources. So examples are, for example, there is a massive infection, heel ulcer, osteomyelitis, transferred to a septic arthritis of the ankle. There is no way you can actually salvage this foot because even after debridement and doing everything you need to fuse the ankle with so much of infection, fusion of the ankle is not possible. A major gangrene of the forefoot, even if you do a bypass, a free flap and cover this small stump, all you're going to get is a calcaneal stump, which we already know. If you give only the calcaneum, there's going to be a trophic ulcer on the heel. So it is not worth salvaging. And late stage Charcos, completely disrupted. Even with a good looking ulcer, it's always better to amputate because the patient, as you saw in our earlier talk, will have good propulsive mobility which will reduce the load on the opposite foot. So in such cases, an amputation with a good prosthesis will actually give a better mobility to these patients, and the longevity of life is only associated with the mobility. So as we said, ours is a directive classification. Stage 1 is preventive podiatry. Stage 2 is surgical offloading as per the location of the ulcer. Crippled foot stage 3, debridement and reconstructive surgery followed by surgical offloading. And critical foot, major amputation without any wasting of resources. All of this has been summarized in a 2016 article, and it is freely available for download in the Indian Journal of Plastic Surgery. So, thank you for your time.
Thank you very much, Dr. Madhu, for your excellent talk. And now it's open for discussion. Any questions from the floor?
What are the use of oxygenation and all those things which are used in terms of
Dr. Madhu.
Sir, there are two types of oxygen therapies, sir. One is local warm oxygen therapy. The other is hyperbaric oxygen therapy. So we use oxygen therapy only when we are not able to revascularize. It's basically a deficiency of oxygen. If the patient already has a good flow, a good bounding pulse, then with an anaerobic infection, he requires a good debridement, not a HBOT treatment. So we would only use HBOT or warm oxygen locally in patients who are not able to get in oxygen to their feet through their normal respiration. So that is the only indication for oxygen therapy, sir.
One other question that we commonly face is what is known as the regional vascular insufficiency in diabetic patients, where even after successful intervention, either in the form of bypass or a distal endovascular procedure, the wounds still are not healing. So what myself and one of our plastic surgeon, Dr. T.M. Balakrishnan, what we came upon is the concept of perforasomes. So after you revascularize, you identify the perforators in that ischemic zone, and you do a free flap based on that. So our articles have been published in the Foot and Ankle Journal. So what's your thought about? Do you face these problems, and how do you go about it?
Sir, we face these problems, but what we prefer, our protocol is, we prefer to debride a little more because we don't want to put a flap on an ischemic base. Because once we put a flap on an ischemic base, the flap is not going to hold to that base because there's ischemic tissue there. And subflap infection can cause severe sepsis. So actually we would wait, give HBOT, do multiple superficial debridements, get the wound nice and pink, and only then go for flapping, sir. We would not hurry into flapping those patients.
And you talking of recurrence following your ulcer, actually the latest JAMA guideline 2003 by Armstrong and Andrew Bolton has concentrated on this. 40% of these ulcers recur at the end of 1 year and 65% at the end of 5 years.
5 years.
That's going to be a huge problem. So how do you...
Sir, that is with conservative therapy, non-surgical therapy. That was specifically with non-surgical therapy. So that is why prevention of recurrence is, with most of our therapies, we have found 90 to 95% recurrence-free interval, that is foot in remission at the end of 30 months. So that is what our statistics is, sir.
Patient with swelling.
Yes, sir.
Mostly we used to get swelling and fever. How can you differentiate the swelling or whether it is early chalk-out? Most of this enthusiastic surgeon, what they say is immediately go for
Yes.
fish.
The red, I think it's called the red hot foot.
Red hot foot.
Yes, sir.
How will you
It's a
manage?
unique. One is we look for systemic symptoms. If they come with fever, we always go towards infection. Second is we take blood CRP, sir. If CRP is elevated, we think it is infection. And third, if we are still not decided, an MRI will clearly tell you whether there is marrow edema or not. If there is marrow edema, we always go towards Charcot. We would not put a cast immediately. We'll put him on a slab, complete rest, and then allow the swelling to come down and then convert to a cast. All of this is in question only when your weight-bearing X-rays do not identify collapse. That is a very, very early Charcot, the class 0 Charcot. So only in these patients this confusion comes, sir. But CRP, systemic symptoms, MRI, they should be able to tell you whether what you're dealing with.
Thank you. Sorry, I didn't get it.
Enhanced counterpulsation or given the pressure on the thing to cause more vasculature. Like when there's no critical limb ischemia distally, where any pressure out there should cause more ischemia. But if that is not there, then an ECP should help in propagating more new vessel formation. Why is that not right?
Did you get that?
I didn't understand it, sir.
Like enhanced pulsation, that is when you give a pressure, the thing mechanically.
Okay,
Oh.
sir.
That should propagate for the cardiac. That's something
Yes,
called
yes.
ECP where we
Okay, sir.
use this thing.
Yes,
But that is meant to have new generation of vessels.
Yeah. So
When if
I'll take that.
distal, ischemia, I understand that it can enhance the distal ischemia,
Yes, sir.
so it cannot be tried. When there's no critical ischemia, it should technically help us in preventing further.
excellent, sir. Actually, we have done a study at MMC and published it also. Myself and one Dr. Raja, now he's in Salem. So what we did, we used it for no option critical limb ischemia. The angios which I showed us absolutely no blood vessels, and option is only amputation. In those situations, what we tried is pneumatic intermittent compression device. So what we did is around 5 to 10 minutes till the patient tolerates, 3 to 4 times a week. We did a study of around 25 patients. We found that encouraged to form a neorevascularization. So that is for no option critical limb ischemia. We don't dare try it on a normal thing, but we published that and we found that around 60% to 70% foot salvage was possible in that patients. Then we went on to stem cells and even CDT and those things like that. That is also an option which can be tried, but cannot be recommended as a mainline therapy. Experimental therapy where there's no other option, we can try those whatever things we can.
Because many times you don't really find a thing when you do the angio, you don't find a
Yeah.
critical ischemia. But then when you have a flap, they again come with an ulcer, recurrent the thing.
Yeah, that's what
That is mostly
Star
because
was-
of biomechanical issues, sir. Another situation where we found
No, sir, despite giving a footwear, despite all that,
The-
we have foot clinic. So despite all that,
Yes, sir.
we still find that many times the flap again, recurrent ulceration occurs.
that most probably then if footwear, there is failure with footwear, you should step it on to offloading surgery, sir. Maybe that will help, sir. And another situation where we found where there is no critical limb ischemia, but suddenly the patient develops gangrene is when they have a massive cardiac event. So we call that the cardiac foot actually. We are just like Ashu has presented the renal foot, the cardiac foot. When there's a pump, the pump failure,
Poor perfusion.
automatically the patient goes for a gangrene.
Many of them have very low EF.
EF.
Yes, sir. Yes, sir. There's very, very little choice we can't go for a major interventions in those cases. Thank you.
What about the plantar ulcer, non-healing plantar ulcer? SSG is mostly failure. Is there any role of PRP, PRF in that?
Yes.
No, the plantar ulcer, non-healing
Sir, for
plantar,
a-
non-healing plantar
No.
ulcer, mostly SSG is getting failed now. I think it's in our experience, splits graft to the plantar as well, plantar, non-healing
Sir,
plantar ulcer.
plantar weight-bearing ulcer, if
Bearing
it's a
ulcer.
trophic ulcer,
Trophic ulcer.
then offloading is the only choice, sir. PRP will not heal. Because
PRF.
if graft is failing, actually we are actually switching on to flaps for the plantar side. Maybe in some other day we will talk about that. Yes.
Exactly, sir. PRP only for no option critical limb ischemia, non-healing ulcer, small ulcer, away from the plantar surface, we are using PRP. Thank you.
So we are going to move on to the next session in the main hall. And before that, I would like to thank the chairpersons, Dr. Madhu Periyasamy and Ilaya Kumar. I would like to call the speakers and chairpersons on the dais for photograph.